Good morning. My name is Amy Daru, and I am a pediatric endocrinologist at UMass Medical Center in Worcester, Massachusetts. And today I'm going to be talking to you about eating disorders and body image and cystic fibrosis. I'd like to especially thank Lena Merjana and Kelly Mason and Dr. Trang Lee from VCU who helped me put this presentation together. So, eating disorders and body image issues in CF are unfortunately not often considered a major priority in most of the CF clinics. However, as we all know, multiple studies have shown that maintaining appropriate nutrition and appropriate BMI are crucial to the lung function and mortality risk for these patients. Unfortunately, the very nature of CF actually makes it a potential risk factor for an eating disorder or disturbed eating in and of itself because of the preoccupation with food, weight, BMI, exercise, etc. And the Cystic Fibrosis Trust, which is an organization from the UK, has created this amazing booklet called Body Image and Cystic Fibrosis for their patients. It was quite eye-opening for me to read through this, and I had developed a very new appreciation for what these patients must go through on a daily basis regarding body image with something as significant as cystic fibrosis. Throughout the booklet, they have multiple quotes from some of the CF patients, so I've actually incorporated those throughout the presentation. So, as we all know, society, TV, social media, etc., magazines, they bombard us relentlessly with images of perfect and beautiful people. And this is already difficult enough for those of us without CF, but for those of us who have, for those of the people who have CF, this can be especially difficult and a very high standard to follow in terms of body image. Unfortunately, as we know, with cystic fibrosis, there's a lot of physical outward illness, outward appearances of the illness that could impact their body image, such as poor growth, delayed puberty, malnutrition, frequent pulmonary exacerbations, barrel chest, clubbing, finger clubbing, etc., that can in fact impact their body image. As a result, this may further lead to harmful consequences, such as developing an eating disorder. Eating disorders defined by the DSM-5 are defined as serious psychiatric disorders characterized by a persistent disturbance of eating or eating-related behavior that results in the altered consumption or absorption of food and significantly impairs physical health or psychosocial functioning. The DSM-5 classify the following eating disorders: anorexia nervosa, bulimia nervosa, avoidant restrictive food intake disorder, and binge eating disorder. They also talk about pica and rumination, but for the purpose of this talk, I did not include those. So the literature provides conflicting evidence regarding the prevalence of eating disorders and eating disturbance in cystic fibrosis. And Tierney et al. Critically looked at 12 research studies examining body image issues in the genders, and what they found is that in females, the females were actually much happier with their body image in general because of the thin body habitus and the low weight, versus the males were much more unhappy because they desired higher strength and musculature and weight as well. Understandably, disease severity can also impact body image. While many CF patients are actually outwardly healthy and don't appear to have CF, those that do have outward signs of CF can really be affected by their outward signs of CF for their body image. So things like barrel chest, poor posture, low muscle mass, delayed puberty and growth, finger clubbing, etc. These things can all impact their body image. And then when you add things in like ports and pegs and wheelchairs and oxygen, this can significantly impact their body image. So obviously, probably one of the biggest risk factors to CF is what you would find in any chronic disease, which is the anxiety and depression that can be associated with any form of chronic disease. However, specific to CF, some of the risk factors include burden of eating, as well as the ease of weight manipulation. So in those that they found sort of monitoring and manipulating their weight like this, they tended to be non-compliant with their pancreatic enzymes, their glucocorticoids, and then of course we all know, as our type 1 diabetics do, CFRD patients tended to not take their insulin. One of the risk factors, like I mentioned before, of an eating disorder in CF is the CF itself, due to the preoccupation with weight, food, body, BMI, et cetera. And then when you add in the increased energy demands and the very demanding dietary targets to these patients, they end up having sometimes a very unhealthy relationship with food and nutrition. And as a result, this may be a risk factor towards developing an eating disorder. While the title of this talk is eating disorders, it's probably more relevant to talk about disordered eating habits, because that was actually found to be much more prevalent in this population than actual full-on diagnosed eating disorders. While eating disorders require a formal and clinical diagnosis, disordered eating is defined as irregular behaviors surrounding eating that do not meet criteria for an eating disorder as defined by the DSM-5's diagnostic criteria. However, disordered eating, as we know, can cause a significant amount of anxiety, and that, along with the preoccupation with food and weight, can be a slippery slope towards an actual eating disorder. So this study I found very interesting by Pumareja, I'm not sure if I'm pronouncing that right, and others, which was completed in 1986, and it looked at 108 CF patients over the course of 3 years between the ages of 12 and 21. And it found 13% of the patients had a full diagnosed eating disorder in the study. They presented with a significant weight loss between 7 and 58%, with an average of 18% weight loss. If you look at Table 2 in this study, it shows the significant symptomology of these individuals who also qualified for a diagnosis of major depressive disorder. And then if you look at Table 3, it looked at the symptomology of those individuals who also qualified for dysthymic disorder. And then Table 4, which I really found interesting, is that they looked at families with a CF individual with an eating disorder, and they found that the most marked point that made these families the characteristic of these families that potentially may have led to an eating disorder was that the family had strong denial about the CF. In this study by Shearer and Bryan in 2004, it looked at 55 patients and ages 11 through 17, and it found that 24% qualified for an eating disorder or severely disturbed eating. Of those who met the diagnostic criteria for anorexia nervosa or the subthreshold for anorexia nervosa, approximately 9% were attempting to lose weight or maintain their weight. And I know that looks a little higher than 9, sorry, that's wrong on the chart. 4% had a fear of weight gain. 36% said that their body shape affected their self-evaluation. 53% said their body weight affected their self-evaluation, and 11% just felt fat. And these were, remember, anorexic or subanorexic patients. So beyond eating disorders and disordered eating, I think it is relevant to talk about mealtime behaviors and interactions that have been noted in the literature. And because these have been especially distressing to many of the families. Many of the parents have described poor appetite, problems chewing food, reluctance to eat at designated meal times, long duration of time to complete a meal, and spitting out of food. According to Sanders, they found that 70.4% of CF parents reported poor mealtime behaviors. And according to a study by Bowen, they found that CF parents, compared to the general population, were twice as likely to give commands at mealtime, were twice as likely to spoon feed their children, and the CF children were 3 times more likely to refuse their food. According to the CF Foundation, as we all know, they talk a lot about the multidisciplinary role of the CF team. For the purpose of this talk, I'm going to focus in on quickly the dietitian, the social worker, and the psychologist. The dietitian is really important because they have the direct contact with the patient regarding food. And so we recommend that the dietitian meet with the family and the patient multiple times a year. Their main job is to really assess the individual dietary needs and preferences of that patient and to make sure that they develop a healthy relationship with food. The relationship of the social worker with the family is also very important. They play a very significant role in the financial and emotional well-being of the patient and ensure that any stressors that are financial or emotional are provided with resources and aid to help the family. And finally, the psychologist has a significant role in terms of encouraging a positive body image for the patient, as well as making sure they're working through negative attitudes and behaviors of the patient. Really quickly, one of the biggest obstacles to assessing eating disorders or disturbed eating in this patient population is the lack of valid or reliable eating disorder screeners that are available, especially there's really nothing available specific to cystic fibrosis. The problem with general screeners is that they can often miss the actual risk or miscalculate the actual risk of an eating disorder in a chronically ill patient. So Quick and All did a quick survey of some of the rapid some of the eating disorder risk assessments that were used in some of the studies. And when they looked at cystic fibrosis, they found the following. This has been covered quite a bit, but as we know, obviously maintaining appropriate nutrition has a significant impact on lung function and mortality risk. And so it's very important that we maintain and be very observant and monitor for these in the cystic fibrosis clinics. So on a quick final note, while medical advances in cystic fibrosis have wonderfully increased the lifespan of these patients, as Catherine very nicely presented to us, there have been other issues, especially obesity, that might be becoming a bigger issue with these families and patients and might be contributing to body image disorders as well. So ironically, what once used to be an issue about being underweight and malnutrition, we're starting to see more and more cases now where body image is being affected by overweight and obesity. And when you look at these studies done from 2002 to 2020, the cohorts in each of these studies, if you look at the percent of CF patients with the BMI over 25, they increased in each of these studies. We also have to address the CFTR modulators and how increased rates of CFRD being treated with insulin might be affecting body image as well. So, like I said, unfortunately, we have a lot to still go with eating disorders and body image with these patients. Most of the studies evaluating eating disorders out there, unfortunately have small sample sizes, inaccurate screening tools that are often self-reported, and they usually fail to formally identify an actual eating disorder versus just an eating disturbance. We need larger studies to identify the prevalence of eating disorders and disturbances in the CF population. And we also need better guidelines as to how to teach and help CF clinics and providers to identify, manage, and treat these patients with these eating disorders. Finally, we need to look into how CFTR modulators affect body image, as well as the increased rates of CFRD that are likely to occur with insulin treatment and how that's also affecting body image. Thank you.